Okay, we will go ahead and get started. Thank you to everyone who is joining in with us. My name is Althea Gonzalez. I'm the North Carolina Program Manager for Hispanics in Philanthropy. A few housekeeping pieces before our presenters join in. First of all, you will all be muted during the course of this webinar. If you have questions, please go to the chat box and submit them to the host. We'll have a question and answer session afterwards, and we'll make sure to address all your questions. If by any chance you lose communication, you can't hear the webinar anymore, you can select Communicate at the top of your screen and teleconference to get the call-in information again. Or you can select Audio Broadcast to have the audio come through your computer speakers. You can also select Full Screen View on the bottom left to get a bigger picture, and then always return to this view as well. So let me tell you just a bit about HIP's Philanthropy Labs. We're using this venue, and HIP uses it across the United States, to provide a rich discussion today on current health trends for the Latino population in North Carolina. This is part 2 of webinars that we're doing for funders here in North Carolina. The first one was on some of the demographic trends in North Carolina for the Latino population, as well as some issues of education in our state. And today we're going to be taking a deeper dive into some of the health trends so that we can understand more fully what the needs are in the near future of our population. And this HIP Philanthropy Lab is part of a series that HIP does throughout the year on a variety of topics. And you can always go to HIP's website and look at the event section for any other webinars you might be interested in. We have 3 fabulous presenters here from North Carolina today. I'm so excited and grateful that they have chosen to spend some time with us to share their expertise. The first one is Norma Martí, who works as a public health consultant for the North Carolina Division of Public Health. She will be our first presenter, and as you can see, Norma works quite a bit with the state's child health insurance programs, Medicaid and S-CHIP, and she provides information about policy and procedural changes that impact access to health care for all of North Carolina's children. She also worked previously at El Pueblo, which is a HIP grantee, and so we're grateful for her contributions as well to the grassroots efforts in North Carolina. Our second presenter is Tom Arcury. Tom has a long pedigree there of a title, so I won't read it all, but to say that one of the pieces that he is most focused on in this presentation is his role as the director of the Center for Worker Health at Wake Forest School of Medicine. He's a medical anthropologist and public health scientist, and he's doing a research program focused on improving the health of rural and minority populations. So we're going to depend on Tom for a lot of the workforce analysis around Latino issues and health. And our third presenter is Steve Davis, who is the Outreach Services Coordinator for Greene County Healthcare. And at Greene County Healthcare, he's been there for 16 years, which is unheard of in most grassroots organizations and health fields. His outreach program has received numerous awards over the years, which you can see there, including the National Migrant Award in 2007 for the best program in the entire U.S. Quite an accomplishment. And he's also been recognized by the Latino community through the Diamante Award for Health and Sciences. And as you'll see at the bottom there, he was responsible in starting the first promotora programs in eastern North Carolina that serves migrant and seasonal farm workers. Since eastern North Carolina is such a huge area that is under-resourced and has a tremendous amount of needs, we are grateful to Steve for giving us the perspective around the eastern part of our state. So with that introduction, I will hand it off to Norma, who will be giving us her perspective on children. And let me pass this to Norma. Okay, Norma, it's all yours.
Thank you. Thank you, Althea. Welcome, everyone. Again, it's going to be a brief presentation, but I've linked everything in terms of data on each of my slides so that if you want to follow up later, you're able to do so. First of all, in looking, just kind of refreshing our memories, I know you all had a demographics webinar last go-round, but looking at data on the Latino population, again, the difficulty in North Carolina is that historically, most data at the state level are for white, non-white minorities, so the trending is kind of difficult to do. So we rely a lot on census data where possible to look at Latino number statistics. And so if you look at the 1990 census and the 2010 census, you'll see why we're having this conversation today. The Latino population jumped from 1.2 to 8.4% of the state's population. And I like this graphic because basically it tells you that there are no counties. We have 100 in North Carolina. There are no counties where there are no Latinos. The dark purple kind of whatever you want to, lilac, violet color are Wake and Mecklenburg, with the homes of Raleigh as the center in Wake and Charlotte as the center in Mecklenburg. So those are the largest numbers of concentrations of Latinos. But if you look at the percentage of population as a percentage of the population, those numbers are really very different. When you look at the blues, the Carolina blues, Lee and Duplin counties show the highest percentage of Latino population. And again, those tend to be the rural counties in our state, so where you see the kind of orangey colors or light peach colors. So issues of urban versus rural are always going to be part of how you look at the population here in North Carolina. And because I represent the state's children's health insurance program's outreach effort, what do you know? What do we need to know about the uninsured children in North Carolina? So what we're looking at basically is the fact that just about 50% of all children are covered by employer-sponsored health insurance. And that's due to a lot of things, which I note there. Probably a higher number if I were to look at that data if it were available for something closer to where we are today in 2012. But again, the fact that folks just can't afford insurance is a big problem. The employer-sponsored coverage for children is larger than any other age group. So again, 11% of North Carolina's children are uninsured. And that number is about 266,000 children. I can't tell you how many of those are Latinos because the data just aren't available that way. But again, it's a large number, and of that number, 68% of them would probably be eligible for one of our public state programs. So when we look at, again, that number in terms of comparison by state and U.S., by children and adult, those numbers are a little staggering for our state. So access is still a very, very important part of the needs of the Latino community, and especially the children. So why is it important? Here are just some numbers that we've crunched from our work that we did in the last 10 years in covering the Covering Kids project. Any one of those bullets you would take and say, what is it, the effect it has on systems across our state, and again, families, specifically families. Something as simple as an untreated vision problem is being left untreated because of lack of health insurance. And so if we look at the state's programs, we have two programs. Both of them are marketed as one. We have one application. It's one portal for families to apply. The only people that call it health check are me and a handful of bureaucrats. Most everybody else calls it Medicaid. But it is distinct because Medicaid covers lots of different populations. So health check really is just the Medicaid for children portion of public health insurance. And then our SCHIP program, our state's children's health insurance program, is NC Health Choice. You can see the numbers of income eligibility on the graph. Both are free or low cost. When we say low cost for Health Choice, NC Health Choice, a family can have coverage for a child for $50 a year. And again, most of the families covered by Health Choice have no enrollment fees. I can give you some numbers on this, kind of looking at the Hispanic versus the total for the state of North Carolina. As of April of this year, we have 142, almost 149,000 children covered by NC Health Choice. Of that, 23,235 are Hispanic, or 15.5% of the Health Choice population is Latino. And if we look at the Medicaid or the health check, for Medicaid for children, we have about 958,000 children enrolled in Medicaid for children. Of that, 153,873 are Latino Hispanic, or that's a little over 16% of the population. So you can see it's a program that really does serve and reach out to our community at large. So if we look at other, look at other data that might affect health insurance and coverage and access issues, I took a look at the CDC's Youth Risk Behavior Surveillance System. It's a long title, but has some really good data. Please go to that link and pull out as much as you want. It measures 6 types of health risk behaviors that are the leading causes of death and disability among young people and adults. Measures prevalence of obesity and asthma among youth, and it includes school-based data. And again, we opt to do state-level data in North Carolina. So just a couple of charts to kind of get you thinking of what you can do in terms of serving the Latino population. Look at I bolded in red what I thought was statistics that were just overwhelming. But even if you look at the bottom one, ever physically forced sexual intercourse, for females at 20% is a large number of, and these are Latino numbers, okay, not the total population. So if you look at this chart, tobacco use, maybe we're doing a little bit better in, preventing that first-time use. But offered, sold, or given illegal drugs by someone on school property, that's a pretty, almost 40% of females, almost 50% of boys, young men, are in that population. So those are really staggering numbers. Again, I encourage you to look at that website. There's a lot of good data there for young people in the 9 to 12 age group. Another one is, I think, and talk about the obesity epidemic. If 92% are eating less than 3 veggies a day, and 84% are having less than 60 minutes of exercise on less than 7 days a week, which is the minimum, I guess, the public health is promoting, we definitely have our work cut out for us in terms of programs to develop to change behaviors. And another data that I thought is probably not very often viewed or studied is a report card done by our Office of Minority Health and Health Disparities annually. And the last report is from 2010. And what they do is they look at a number of factors, health factors from our state-level data, and base the white population and then measure the other populations, minority populations, around that base, so that we're able to say whether we're meeting or close to or at the same level or better than the white population. So the A's and B's and C's are usually pretty good. And I'm not going to read these because I know you all can read. These are the things that we're doing right within our Latino population. Okay? And then if we take the D and F, there's the things that maybe we could do a little bit better, that our population is definitely lagging behind the general population, again, and the white population specifically. So which one of these can we tackle? Which ones are we tackling? How difficult are they? And in terms of health, HIV disease deaths seems to be standing out a lot. What can we do about poverty? And that's a big issue, because poverty, as we know, affects everyone. And if you look at, the current focus in terms of frameworks that we're looking at in public health. We're looking at life cycles. We're looking at, how do we begin life, and how does that affect our health across age groups. And so it's really important to be looking at the F's when we look at women with late prenatal care, because again, that late prenatal care has already, affected that child in vitro. And so children who don't have health insurance, again, is somewhere where we're not successful. Pregnancies to teens, age 15 to 19, and again, that's something that I know we're working on as a state, and looking at programs to better serve our Latina teens. But looking at those, which one would you consider the most important? They're all important, but which one can you tackle, and which one would be approachable in terms of programmatic strategies that you might consider? And I'm going to pass the ball over to Thomas. Thank you.
Oh, my. Okay, so thank you very much, and thank you for the opportunity to speak with you all today. My phone just started ringing. That's interesting. So as it says there, I'm the director of the Center for Worker Health, and what I will be talking about today is looking at occupational health and some of the issues surrounding occupational health for Latino workers in North Carolina. As a little bit more background, I started to work in this area when I first arrived in North Carolina in 1995, and I've been doing research with farm workers as well as poultry processing workers and construction workers now over that period. So let's start with what I call the Latino paradox, which is a primary occupational goal of Latinos who come to North Carolina, particularly the immigrants, is to provide financially for their families and to ensure a secure future for their children. At the same time, if you notice the industries I talked about, poultry processing, agriculture, construction, Latinos in North Carolina are often in the least desirable jobs, farm worker, roofer, in the most dangerous industries. Farming, fisheries, forestry are extremely dangerous, as is construction in terms of number of fatalities and number of industries. And they often have the fewest, and these are the industries and the jobs with the fewest health and safety protections. And if you know anything about agriculture, you know that agriculture is exempt from most OSHA regulations. And in fact, in agriculture, 12 and 13-year-olds can work in the fields. At the same time, we have to be thinking about occupational justice when it comes to workers immigrant workers. And now I have a very simple definition of occupational justice, which is not having to get sick in order to make a living. Now, there's several components of that not having to get sick. One is having a livable wage with appropriate benefits, working in a place with a positive work safety culture, having a safe work environment where there are hazards identified and addressed, there's appropriate training provided, and that you have appropriate personal protective equipment, or PPE if I start talking in jargon, and you have access to health care. These are not the job characteristics for most Latino workers in North Carolina. So many Latino workers not only do not make a living wage, they often do not make minimum wage. And at minimum wage, remember at we'll say if you're making $8 an hour, if you work full time, that's an income of $16,000 a year. We have shown that the work safety climate. One other thing about those wages is many of these workers seldom have any sort of benefits, health or vacation or retirement. The work safety culture, as we've seen in our research, is not very strong. Most places care more about production than they care about the safety of their workers. The work environments in agriculture and in forestry, as well as in some of the manufacturing, are extremely dangerous. We have many stories of that. We have found that training is seldom provided to Latino workers in any of these industries. So, and then on top of it, as we've also seen, there's limited access to health care for these workers. Now let's look at some of the industries and jobs that Latino workers tend to have in North Carolina. Within agriculture, though not all Latinos are migrant and seasonal farm workers, almost all migrant and seasonal farm workers in North Carolina are Latino. Similarly, many Latinos now have the job of chicken catcher, which are the men who have to go into the large chicken barns with 30 or 60 or 90,000 birds and catch them with no personal protective equipment on whatsoever, working in the dark with equipment. Very dangerous job. Forestry, they work as pine straw workers and tree planters. In fisheries, they're the crab pickers, often having H-2B visas coming up from Mexico to pick the cooked crab out and pack it for sale. In manufacturing, the poultry processing plants in Burke and Surrey and Wilkes County, as well as Chatham County down in Hoke County, generally hire Latinos, and that's the major part of their workforce, as opposed to some other plants where have lots of African Americans. Construction, most roofers now are, particularly residential roofers, are Latinos. And then in the service industry, those who are your wait staff, your hotel cleaners, your lawn maintenance and landscaping workers are largely Latino these days. Now, what kind of exposures do these workers have, and what are some of the outcomes? Well, in agriculture, forestry, and others, workers are exposed to pesticides and other toxicants, petrochemicals, fertilizers, what have you. The health outcomes from pesticide exposure are now widely documented. We know that acute intoxication, poisoning, results in coma and death often, if not just being very sick. However, long-term exposure to small amounts of pesticide where you don't even know you're being exposed have been shown to be related to neurological decline, memory loss, those sorts of things, increased rates of dementia, cancer, respiratory illness, reproductive health, and skin disease. We have data on all of those. Many of these workers work in the heat, and that's a tough thing to do in North Carolina. We have extremely high rates of heat stress and heat stroke, and North Carolina experiences some more, I believe, experiences more heat-related deaths among workers than any other state in the union. Particularly in the manufacturing, the repetitive motion exposure has resulted in high levels of carpal tunnel syndrome among Latino workers. The awkward positions in many of these industries, bending over, working stooped, what have you, results in musculoskeletal disorders, back pain. There's a lot of risk for slips and falls, and you can see the different injuries that come from that. And finally, there's a lot of exposure to organic and inorganic dust, and as I say, in poultry houses, on farms and plants, which result in respiratory disease. Another area that we need to be concerned with is what we refer to as the organization of work, or how work is done. In many of the jobs that Latino immigrants have, we have to be concerned with abusive supervision and harassment. I can tell you stories about how workers who, without documents in particular, are harassed and abused by their supervisors because the workers are too fearful to complain. We have contingent and temporary work. Contingent work is basically you work when you're needed. And so you come in any time of the day or night because you need to work. And that sets you up for risk for injury and harm. There's shift work, and again, part of the organization of work for Latino workers is the absence of health insurance and often even workers' compensation. The outcomes from this often include mental health from the abuse and harassment, and there's also inadequate health care. Now, there are virtually no safety regulations current for several industries in which Latino workers in North Carolina work. As I say, almost none for farm workers, lawn maintenance workers, and landscapers and forestry. In other industries we found, such as construction and manufacturing, what regulations exist are regularly ignored. We have been told by roofers, for example, that they're told when they're hired, there will be no workers' compensation for you. If you get hurt, we'll pay a week's salary for you, but we will not pay any of your hospital costs. And then they are not provided with any of the personal protective equipment, which OSHA requires for roofers. So how should we respond to this? The odds are, given the current economic situation, that these occupational exposures for Latino workers in North Carolina are not going to change anytime in the next several years. We can expect them to be there. So I am proposing that what we need to think about is research, intervention, and policy as ways to address these issues. In terms of research, research is what I do, so you have to understand that. We need to continue our focus on major occupational groups, the farm workers, the poultry processing workers, the landscapers, and we need to have better surveillance. Right now, we do not have a surveillance system in North Carolina for most occupational injuries in these major industries. We've recently started a sensor system for pesticide exposure, but there are a number of problems with that because people actually have to report them to a physician for them to be reported to the state. We also need to expand the focus of our research to other occupational groups and to other groups of people. So, for example, there's been almost no research done on Latino service workers in North Carolina that I know of. We don't know much about women workers in North Carolina, nor do we know much about child workers in North Carolina who are Latino. And these are major groups out there who are experiencing occupational injury. The research is needed for four purposes. One, we have to know who is working. We really don't know who's doing the work and what industries they're in. We need to know what their exposures are, what they're exposed to in the workplace. We need to know the health effects of those exposures, and we need to learn how to prevent those exposures so the health outcomes are not there. In terms of intervention, one of the major problems we have is for most of these industries, occupational health investigators, interventionists, health educators do not have access to the workplace. We have very limited access to farm workers except where they live, not where they work. Poultry processing workers, we have tried to work with poultry processing plants in North Carolina and have been refused access to their workforce. So we have to think about community approaches to health and safety intervention, using promotoras, as Steve has done, as well as others, and using outreach workers from clinics. When we develop these, we have to make sure that they're educationally and culturally appropriate. We have to think of new media. Remember, many of the Latino immigrants have very little formal education, and we have to think of different ways to approach this population to provide them with the information they need to protect themselves in the workplace. Finally, using community educators, I think, is extremely important in getting to these workers. When we look at policy, there's four issues that I list here that I think are extremely important in terms of occupational health. First, we need to compile existing data indicating exposures and health outcomes. Again, we need better surveillance. We have almost no surveillance, so we don't know exactly what injuries are occurring at what rates to which people. We need to document if existing regulations are not being enforced. I know they're not being enforced. I see it every day. But I think we actually need to document this because when we bring those complaints to people in control in state government who are the regulators, they say you have no evidence, we don't believe you. We need to indicate areas in which new regulation is needed. For example, the whole issue of child labor in agriculture. We really do need to address policy issues there. And we need to work with advocates to support legislative goals to make sure that the policy that we need to protect these workers is implemented. And I believe that's it for me. And so I'm turn this over to Steve.
Good afternoon, everybody. Hope everybody can hear me. I had it on mute, but I think it's good now. Just wanted to think that David Tomlin did a wonderful job, and just wanted to kind of touch base and speak on more of a personal level what I see here on a daily basis at a migrant community health center and what our outreach people see. like I said earlier, I've been here for around 16 years, and some of the big things that we've seen over the years and the barriers to care, one of the biggest ones, of course, is transportation, especially the HJ workers that come here under contract. You know, they're here legally, you know, brought here by the North Carolina Growers Association, but a lot of times what happens is they're brought here on buses, dropped off in the middle of nowhere, kind of like here in Snow Hill, where I'm at right now, and they're kind of left at the mercy of the grower or maybe the crew leader that's in charge of that particular farm. So I hadn't seen that really get better in the 16 years that I've been here. And a place like Greene County, there's no public transportation available. So even if they wanted to get here, they're not able to get here because there's not taxis, there's not a bus service, there's no way for them to get here, and sometimes they're at the mercy of the grower. And if there's not outreach programs like we have here, a lot of times they just don't get health care. Another big thing that we see is here at Greene County Healthcare, about 50% of our staff are bilingual. So here it's not as big a deal, but when people are referred out from Greene County Healthcare to specialists and other different agencies, we're seeing that even though this particular population has grown so much in the past 15 years or so, there's still a lot of organizations and agencies that aren't able and willing to provide interpreters. So a lot of times when people are able to get services, there's nobody there that communicates the services in the language that they understand. And another obvious one is lack of health insurance. You know, majority, if not all of migrant farm workers aren't going to have insurance. It's not something that's offered to them. And unfortunately, with the migrant fee-for-service program, that was a type of insurance program for farm workers through the state of North Carolina, was discontinued a couple of years ago. If they are fortunate enough to live near a migrant and community health center, we do offer a sliding fee scale, but when they get referred out, a lot of times they aren't able to afford the fees that specialty care comes with. So a lot of times they'll come into our clinics, we'll treat, you know, the basic, and if it's anything that they need to be referred out to, a lot of times they don't go because they're not able to afford the services. We've also experienced over the years that we work in about 10 counties here in eastern North Carolina, and camps change from year to year. We consider a camp to be it can be an old trailer, an old farmhouse, or a barrack. And it always amazes me that every year we find camps that a lot of times are within 10 miles of a migrant community health center, but the workers don't realize that service is available to them. So, you know, a lot of occasions there may be services available, but the population is not aware of it. But then there's the flip side of that, is when there are facilities that are available, a lot of times the hours, the workers aren't able to go. A lot of the workers are here, you know, as Tom talked about earlier, undocumented. So they're scared if they do get off during work hours that they maybe get fired or be sent to another area where there's not as much work. So a lot of times when they do seek health services, it's when they're not working, which is not very often, you know, evenings late and on the weekends, and usually that's just a Sunday every now and then during the peak of the season. So a lot of times, you know, the hours of service, it's really hard for this particular population to get in and get health care. And like I said earlier, you know, fear of if they miss work, they're not going to have a job to go back to. And another thing that I've seen is, you know, there's some wonderful programs in North Carolina that are just providing some awesome services to the Latino population, the farm worker population. But the sad fact is that there's a lot of areas that are lacking. So if you're a farm worker that comes to our area of the state where we're able to provide transportation, deliver medicines to you, you know, kind of case manage your medical situation, you know, it's just kind of the luck of the draw. If you're a farm worker that's somewhere else and there's nothing there, then if you get sick, you're just kind of out of luck. My recommendations Like I just said earlier, there's too many gaps in coverage. There are some sites that offer these wonderful expanded services, and then you might just go 60 miles down the road and there's nothing there for that particular population. So I think, until there's more of looking at the coverage areas and trying to expand the coverage area to include all areas of North Carolina, that there's going to still be a gap in coverage for the Hispanic and Latino population and also the farm worker population. Also, the Latino population, obviously has grown leaps and bounds the past 10 years. It seems to be leveling out somewhat with all, I guess, the immigration stuff going on right now. But I don't foresee, and this is just my personal opinion, I don't foresee this particular population going away. I don't think we'll see the increases in the census 10 years from now like we have the past two censuses. But I do see this population staying where it's at, excuse me, and possibly even growing some. Also, we have farm workers that bring their families, and their home state, for example, may be Florida. In Florida, they're there 7 months out of the year, and in other states, the other months. And what we've seen is that, excuse me, let me get some water real quick. Sorry about that. What we've seen is when they're in Florida, their children have state, Medicaid, for example, coverage, health insurance, but they only come here for, say, 3 months, 4 months. And what we have discovered is no matter how much we encourage them to try to reapply, that it's too much red tape and too much stuff, hoops they have to jump through, and by the time a lot of times they get their children requalified, they're moving on to another state. So I wish there would be, some type of way that maybe the Portability Act, where they can go from state to state. But I know that's something that's being looked in by other people at the time. But until that happens, I think we're still going to have a lot of uninsured children here as well that are migrant farm worker children, if nothing else for that main reason, that all the hoops they have to jump through just doesn't make it worth it to be here 2 or 3 months to get coverage. Also, better access to governmental transportation. We do have transportation through social services, and unfortunately, if you're not receiving services through them, you're not able to get transportation. And I've seen a number of times that the van would just be sitting there, although I do know they stay pretty busy. But there's times when, if that could have been accessible to other people who live in the community, such as that particular population, farm workers, Hispanic, Latino, it would have helped people to have better access to health care when we're not able to get them to their appointments. And also, like I said earlier, you come here, you pay your minimum sliding fee payment, we'll see you. But when it comes time to refer somebody out, a lot of times that's where the problem arises, where they're not able to afford the specialty care that they need. So it would be nice if there were other options available, because a lot of the agencies that we refer people out to have gotten to the point now where they won't even accept they won't even accept a payment schedule, a monthly payment schedule. A lot of times they're asking for pretty much the money up front. So what does the future hold? Like I said earlier, I don't anticipate this particular population getting any smaller. I definitely think it's going to get bigger. Don't know by how much, but I definitely think it's, a population that's going to keep growing here in North Carolina. I think it's important that we try to get more agencies and organizations to hire, if they don't want to hire interpreters, to try to find more bilingual staff. Definitely think that's a big problem. And I know we're here talking about the Latino Hispanic population, but we're also seeing increases of other populations as well that are non-English speakers. So I think the language problem is just going to get worse over the next 10 years. Also, it would be nice if the state would be able to start the migrant fee-for-service program again, and that wouldn't cover all the Hispanic Latino workers, but maybe it would at least cover the farm worker population. And I think until that happens, until there's some type of insurance for that particular population, that they're going to have poor health outcomes because they're not going to be able to afford the care that they need. Also, what we've seen is we're seeing, some people that are reaching out and providing interpreters, and even though they're providing linguistically appropriate health care, a lot of places tend to not provide culturally appropriate health care. So we've also encouraged people to not just understand the language of the people they're working with, but also the culture, so they're able to provide better services. And also a lack of health services in many parts of the state, and I've already said that a couple of times, until I think there's more areas that are able to provide more services. That's definitely going to be a problem. It's just going to be the luck of the draw, especially when we're talking about the Latino, Hispanic farm worker population. If you live in a place where there's no services, you're not going to get services. So I think it's something that the state should look at, so we're able to possibly expand services so there's not so many gaps throughout North Carolina. And me being the director of outreach, of course I had to put that in there, and I put it in there last. I think outreach services should be a priority. Greene County Healthcare, 16 years ago, we served 150 Spanish-speaking patients the first year I was here, and in 2011 we served 20,000. That's a pretty big increase, and I think a lot of that was because we do have an outreach program, and we're out there letting this particular population know what services are available to them in a language that they understand. And for the most part, that's kind of my opinion and where I think we're at and where we're going to be in the near future. And thank everybody for listening. And I'm going to pass the ball now.
Thank you so much, Steve. Appreciate that, and thank you to all of our presenters. Want to take a moment now to entertain questions that you all may have, and while you all are putting questions into the chat window, we have a couple questions here in our office for folks. First of all, Norma, I'm wondering if you can say a little bit about what's happening with our undocumented children who may not be eligible for some of the state insurance programs.
Right, and that is important to state that the programs cover citizens and documented children. Doesn't matter what the parents are, but the children have to be documented and or citizens. Basically, the uninsured are a lot of them are those children. The community health center system across the state provides good primary care to those children, and they're kind of the safety net for those families. But the fact that again, even buy-in is not an option, and even if we're looking at the Affordable Care Act, buy-in is still not an option for anyone in the country that's not a citizen. So it is a big issue.
Yeah. Okay. Great. Not great, but yeah.
No, it's not. No, and it is the largest. And I want to piggyback on Steve's comment on the portability of Medicaid and S-CHIP across the state. A lot of our children, the parents won't change because they're in another state a longer period of time, and it becomes cumbersome to them to keep track of too. But we're incurring a larger health care cost for that child or that family because of that. When we can easily look for ways to make especially if they're migrant workers, that we can make some kind of documentation across state lines, as some other states have done, Texas, for example. So I think we really need to push to make that happen.
Thank you, Norma. There's a question from someone here. Is there an estimate of the number of Latino migrant farm workers in the state? I guess that's a question for Tom or for Steve.
That's a really difficult number to come up with. There's somewhere between, if you look at the Employment Security Commission, 50 or 60,000. If you look at my numbers, or what I consider to be a better number, between 100 and 150,000. One of the problems with estimating the number of farm workers is that at any one time, there may be 50 or 60, but there's turnover. So there's several different waves of farm workers sometimes and for different crops. But the number I tend to use is 100 to 150,000 migrant and seasonal farm workers each season in North Carolina. That does not include any children or spouses that may be traveling with them.
And I'll ask you, Tom, a follow-up question. You talked about how North Carolina does such a poor job in worker protection for these industries. Do you have any sense of how North Carolina compares to other states in the country in their worker protection for these industries?
We're probably about par for most of the Southeast from everything I've read and talked to other folks doing research in the Southeast. We're not as good as a couple of the states on the West Coast. So, for example, both California and Washington have implemented heat stress regs to help keep people from getting heat stress. Washington also checks at least pesticide applicators for cholinesterase, which is an indicator of exposure. Talking to my colleagues in the Northeast, they seem to have a little bit better, but overall, I think if you look across North Carolina, the Midwest, even the far West, these are not unusual circumstances. There's a few states that do a few things better. In many ways, North Carolina has better regs than other states in the Southeast. But as we've looked at it, for example, in terms of issues of migrant farm worker housing, even though we have stronger regulations, our research shows that those regulations are often violated.
Mm-hmm. Okay. And Steve, I want to ask you about farm worker children. I know at this point there were some efforts to get child protection laws for farm worker children, and advocates thought it should be a no-brainer that children shouldn't be exposed to these sorts of things, that even though undocumented children or the issue of immigration might be tough for North Carolina, that everyone should be able to align with the need to protect our kids. And it seemed to have been not as easy as they thought it would be. Can you talk a little bit about the resistance to protect our farm worker kids?
Well, I think there's definitely a push out there from advocates to get children out of the fields. I mean, there's a lot of obvious risks, pesticide exposure, they're around big machinery. But unfortunately, I was born and raised here in eastern North Carolina and grew up farming and remember, as a 10-year-old, 11-year-old, 12-year-old learning how to drive a tractor, out there working in the fields. I can remember many summers out there with my shirt off and in flip-flops, so I could get a suntan while I was out there working. There's no telling what I was exposed to. You didn't really hear of any pesticide safety trainings or any way to protect yourself. Or I had skin cancer at 22 years old, so I'm sure that came from working with my shirt off all summer, every summer. But I think, unfortunately, that's kind of the mentality is that, this is how it is in North Carolina, but unfortunately, it shouldn't be that way. Things have changed from 20 or 30, 40 years ago. There's not as many family farms, and I think that's the excuse that a lot of people try to use that like in my situation, I should be able to work on the farm I grew up in. But I think now there's definitely too many risk factors for children working in the fields. And, we're talking about 12-year-olds being able to legally work in the fields, but also what we see as outreach staff, outreach workers, we've gone out there many times to visit families during the workday, and there'd be 4-, 5-, 6-year-olds out there not working in the fields, but on the corner of the fields or running through the tobacco rows because the parents don't have a babysitter. So we're not just talking about the kids that young working in the fields, but, we see cases where there's children even younger than that are out there around the equipment and all and around the, the pesticides.
Steve, there's a follow-up question for you about, and following up on what you're saying is, what are the top reasons that the farm workers go to the clinics when they do go, and what are the major health issues that aren't being addressed by the clinics?
Okay, I would say, some of the main reasons that people come to the clinic would be contact dermatitis, lower back pain. You know, unfortunately, we're seeing more and more undiagnosed hypertension, diabetics that aren't aware they have those diseases or illnesses. But at the same time, reasons that people don't come is because of the fear that I stated earlier. You know, a skin rash that gets treated earlier might not turn into something serious, but a lot of times we don't see the workers until they're at a later stage in their illness because of the fear of being fired or not being able to find a ride to get into the clinic. But I would say overall, the main things that we see from the farm worker population and would be, green tobacco sickness is a big one also that we see every year. The lower back pain, the contact dermatitis problems, and pesticide exposure. Unfortunately, that's a harder one to prove, and I think sometimes our providers miss that and confuse it with other illnesses because that can also have some similar symptoms to heat stress, just to mention, one of them. But anyway, that would be the main things that we see, and I see there's a question about some farm worker advocates. FAN is a big advocate for farm workers here in North Carolina. I think that stands for the Farm Worker Advocacy Network, and that's through also SAF is a big advocate for farm workers here in North Carolina, and that's SAF, Student Action with Farm Workers.
Mm-hmm. Tom, do you have anything to add about what some of the conditions are that you think are really prevalent in the migrant worker community?
Yeah, well, I echo what Steve said in terms of some of the issues, particularly about child labor. I was actually had a meeting along with representatives from some of the FAN organizations like NC Justice Center, SAF, NC Field, with Commissioner Barry to ask her to support keeping 12 and 13-year-olds out of the field, and she had her objections to doing that. One of them were, well, this is an immigrant issue, and when we told her, no, these are our children, most of these kids, they may be Latino, but they're American citizens, she did not have an answer to that. Her other answer is that she had to make sure her constituents, which was the North Carolina Farm Bureau Federation and the commodity groups, approved it. Another set of issues that we need to be concerned about is farm worker housing. Farm worker housing is atrocious. We're putting people at risk just in the housing they live in. We found in our study that a third of the water in farm worker camps which we tested had total coliform, and two cases out of 180 had E. coli. This hasn't changed since research that was published in 1990 by Steve Soselsky on farm worker camp water quality. Another important issue that we really have to pay attention to, particularly with migrant farm workers, is that we're taking men from their families and their wives and their girlfriends, and we're putting them in camps with other men for several months out of the year. And these men understand the issues of HIV and STIs, and they're hungry for information on how to protect themselves. And so we really need to think about that. Although it's not strictly an occupational issue, but the occupation results in really high rates. And just as an example, we tested 100 farm worker men for syphilis a few years ago. We found 2 of them had active syphilis, and you say, wow, that's only 2%. In the same year in the U.S. adult population, the syphilis rate was 3.65 per 100,000. And we found it, therefore, at a rate of 2,000 per 100,000. This is a whole other issue that we really do need to address in our outreach, in our education, in our provision of health care.
Excellent.
Yeah, and definitely that was one of those statistics that screamed out from surveillance data. Mm-hmm. And it's not necessarily farm worker associated, but it is Latino.
Right.
And so it sounds like from some of your comments that considering North Carolina's heavy focus on agriculture and poultry and those sorts of things, that it's going to be really hard for us to change some of the legislative policy issues that are causing a barrier to health for our Latino workers in the state.
Well, that's been my experience. Agriculture has a lot of say in Raleigh. Agriculture is a major industry in North Carolina. And at this, and so getting that by. But I don't think you should forget other industries. I think you need to keep an eye on things like construction, where more and more of residential construction workers are Latino. I had my house roofed the other 2 years ago, and I asked the contractor, who was a native of New Jersey, I said, how many of your crew are Latino? And he looked at me sheepishly. I said, that's okay, you can tell me. He said, all of them. He had just hired a foreman, a bilingual foreman from Texas, so that he could work with his own crew. That gives you an example, and I think you also need to look at a lot of the service industries, because those really fly under the radar, so to speak. We don't know what's happening there. And we have a lot more Latinas, in particular, working in those service industries, whether that's hotels or restaurants. And we don't know what's going on there in terms of occupational health. We do know from some research that there's a high risk of harassment and abuse in those industries. So again, agriculture is important, and I've spent a good part of my career doing research with farm workers and doing interventions with farm workers, but I think we need to look at these other industries also.
Okay, great. Time for one more question. Is there one out in the audience that is bubbling up? Okay, I don't see one, so let me give you each 1 minute to give us a parting comment from your perspective and your expertise in the state to our audience. Norma, we'll start with you.
Yeah, for me, it's the issue of again, keeping in mind health issues as a life cycle, where, you know, we can't separate the work of a farm worker from that child that's going to be birthed a year from now or 9 months from now, because the work of that parent affects that child's development. And so we need to look at ways that we can educate and provide, you know, just total access to those families. How that happens, I'm not, you know, if I knew, I wouldn't be here. But we do need to provide access to health care, and if we continue to deny populations that access, we're all going to have issues. And, you know, I always wonder how we can justify having farm workers who are not maintaining their health collect the fruits and vegetables that we're all supposed to be eating. Mm-hmm. And that's all I have to say.
Thank you, Norma. Tom?
As I say, I am at heart a researcher. That's what I do. I'm a scientist, so we need to document what we're doing. But more importantly than continuing research and better surveillance of occupational health among in this population as well as other populations in North Carolina, I think we need to use the knowledge that we have, and there is a bunch out there. We have a lot of documentation now, and address the policy that needs to be changed or at least enforced, so that we can improve the conditions, reduce